with regards to mental health in folks with developmental disabilities. For those of you on Zoom who do not know me, my name is Jen Smith, and I'm a psychologist here within our division. And I am the director of our LEND program. And from a clinical perspective, this is kind of where I started my career, is working with kids in particular with developmental disabilities who also had mental health concerns. So this is something that I feel very passionate about, and I know a lot of people do too. And I just want to give kind of a disclaimer that some of the things that we talk about can be very challenging, and just to let you all know that you are not alone. So if there are things that kind of hit close to home, whether it be from an individual yourself, struggling with some of these concerns, or as a family member, or as a provider, or just somebody who is in our field, who cares about this community, it's very important to kind of recognize, the supports that are out there. And so we hope that we can, kind of provide that support for you all. So just wanted to kind of clarify, and emphasize that moving forward. And we are going to be presenting on 2 different days. So today is part 1, and then we will do part 2. I think it's in a couple of weeks, actually, just due to scheduling difficulties and me being able to be more flexible than some of the other presenters. So our next session will be on March 7th. But I have a wonderful co-presenter who is going to be presenting with me today once she is out of clinic serving our patients. So her name is Lauren Jones, and she has presented in here a couple of times for the LEND group. And she also is very passionate about this community and serving people with DD and co-occurring mental health conditions. So I'm excited to present with her. So the things that we're going to talk about today, we're going to talk about just what dual diagnosis means and the history and kind of how we got to where we are today with this community. Talk about some of the strategies that are used to assess mental health concerns in individuals with developmental disabilities, and then talk about some of the reasons why this has been challenging in the past and still continues to be, but some of the challenges that are related to our specific community that make this especially challenging for diagnosing mental health concerns. And then we're going to move into some of the most prevalent co-occurring conditions. And so today we're going to talk about 2 of the conditions with ADHD and behavior disorders. We recognize that you all have had kind of background sessions on ADHD and behavior, so we're going to go through those relatively quickly, but I think it's still important to collapse kind of into this topic because they are considered mental disorders. So we are going to start there, and then next time we will jump into some of the other co-occurring conditions. So just wanted to kind of frame this from the standpoint of why this topic is so important. And this is, kind of where some of the trigger kind of warnings come into play, that the outlook for people with developmental disabilities and mental health conditions, the outcomes have not been great so far. And when we look at some of the characteristics within this community, there's a lot of things that can be very concerning. So one is that they tend to have fewer support networks and just fewer peer relationships, people that they are close to. And that can also lead to a lot of isolation and just kind of feeling out, kind of out of their community. And then that, in turn leads to this idea of segregation and kind of having a hard time getting out into the community with their peers and doing, just kind of typical things. So we'll talk about a lot of this symptomology when we talk about some of the specific diagnoses, but one of the things that we recognize is low self-esteem in this population, as well as poor coping strategies. and kind of stress management, and then also poor problem solving and conflict resolution. And a lot of this is tied into this idea of poor self-worth and poor self-image. So again, what we are trying to kind of look at as we talk about this information is kind of just be transparent about where we are right now, kind of within our field, but then also provide some hope of what is being done and how you all can be a part of that. So we will kind of talk about strategies that are effective for our community as well. So just want to start out talking about some background information because this is how we make all of our decisions based on this particular manual. So it's the Diagnostic and Statistical Manual of Mental Disorders, DSM-5. And so this is something that gets updated every so often, tries to kind of evolve, with the field. But it's important to think about kind of the continuum of mental health that, when we're talking about an actual mental disorder, this is the actual definition. So a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. So a lot of fancy terminology here, but the things I want to point out are the idea that it has to cause clinically significant disturbance. So it has to be interfering with a person's life because everybody kind of goes through these episodes of having some of these concerns, but whether it's diagnosed as a true disorder depends on the level of impact that it has on the individual's functioning. And you can see that there's a lot of different aspects that go into this, looking at the cognition, looking at emotion regulation, and behavior. So if you think about all of those, things that can fall into that category, you can start to think why our community of developmental disabilities is at particular risk for mental health conditions. So when we think about dual diagnosis, I just wanted to clarify what that term means, because you may have heard it, but it may have been for something different. So what we are talking about today are two diagnoses that occur together. So in this kind of example that we're talking about with developmental disabilities, it's both having a mental illness or a mental disorder and an intellectual or developmental disability. So when we look at this, you can also have dual diagnosis referred to with mental illness and substance abuse. So you might have heard that as, kind of dual diagnosis. But what we're talking about is with mental conditions and with developmental disabilities. So when you think about just in your own work that you do clinically, what examples have you seen where you have two occurring conditions happening within the same individual? And feel free to grab the mic. I think that there's a couple, and actually this table arrangement might work better for the mic. We'll see. So what examples clinically have you seen?
I was going to say anxiety and intellectual and developmental disabilities is the big one I see, especially in treatment with staff.
For sure. Yeah. So anxiety, we're going to talk a lot about.
I've seen autism and bipolar disorder, intellectual disability, depression.
Mm-hmm. Yeah. So depression and bipolar co-occurring with intellectual disability or autism. Yeah, for sure. Any other ones that stand out? So we have anxiety, depression, bipolar. Yeah, Brad.
Something that I've not necessarily seen personally, but I know can be associated, can be like just an OCD or something similar.
Yeah, for sure. And we'll talk about that a little bit more when we talk about anxiety as well, and how that can present, you know, in our community also. The other thing that I want you all to kind of think about, and I think you all went down kind of like what you typically think of with mental health conditions, with anxiety and depression, but also like those attention deficit disorders, as well as the behavior disorders. And what we see is that this changes kind of over time in the lifetime of the individual. And so that is something that, you know, we'll talk about kind of the trajectory of what we see in our community as well. So one of the things that is really complicated about giving a talk like this is that there are a lot of different developmental disabilities. And it's important to keep in mind as we talk about these things, we'll try to not talk about, we have to talk about generalities, but we want to recognize that every individual is different and every condition is different. But this is kind of where the work is being done in this area. So we have a lot of research that is being done in autism, a lot of research being done in Down syndrome, thanks to our friends here at Cincinnati Children's. And then also with spina bifida, same, doing a lot of work in that area within our clinic. And then cerebral palsy and Fragile X syndrome are also other particular developmental disabilities where some of this work is being done, as well as just kind of the general intellectual disability. Where this gets kind of complicated is that for a long time, it was thought that individuals with intellectual or developmental disabilities couldn't have a mental illness or some sort of mental disorder. So any thoughts on why that might have been kind of the thinking kind of back kind of 1950s, 1960s? Yeah, Simon?
My guess is that the belief was like, it's intrinsic to the intellectual development disability, not something separately occurring.
Yeah.
It's just like, it almost be like, quote unquote, they're actually beating a dead horse of like diagnosing somebody with depression and autism. Or
Yeah.
depression.
Exactly. So it kind of back in the day, it was thought that everything could be attributed to the diagnosis of the developmental disability. And as a result of that, you know, we started to see this just lack of understanding when it came to intervention, because they didn't recognize that our community could also have these mental health concerns. And so they often went unrecognized, which unfortunately is still kind of happening today, but then also untreated. And so this research, you know, just started to emerge in the 1970s. So if you think about that, you know, we are finally kind of catching up and seeing that our community can have these diagnoses as well. And unfortunately, because of that thinking, there were a lot of myths that were around dual diagnosis. And so one of the things was from a behavioral standpoint, kind of assuming that anybody that had kind of maladaptive or disruptive behaviors was because they had an intellectual or developmental disability. And the other thing that was really, I think, overemphasized is this insistence on medication, thinking that medication was the only way to go with our community. And, you know, that therapy in the traditional sense was not going to be effective for our community because of maybe their cognitive abilities or their language skills. So again, kind of all of this kind of led to the different systems, which we'll talk about on day 2, the different systems, you know, kind of having this idea that, oh, this isn't ours, like this isn't one of our like people, this belongs on the other side, you know, either within the DD system or the mental health system. So we'll talk a lot about how we can hopefully kind of bridge that gap between the two systems when we meet next time as well. So the thing that you all just described of thinking about, okay, it must be because of that developmental disability. There's a couple of terms that are used to describe this. One is behavioral overshadowing, where we think that any of the behavior is a learned behavior and not something that is a part of an underlying condition, like a mental health concern. And just like you all talked about with kind of blaming or like attributing the mental health concerns just because you have a developmental disability is referred to as diagnostic overshadowing. So for a long time, this is kind of how we viewed everything. And for a long time, it left our folks without the services that they needed. So we're gonna kind of switch gears and talk about some of the risk factors that are associated with mental health conditions. And one of the things that I would like to kind of clear up too is when we talk about this, a lot of this is borrowed from research that is done with neurotypical folks. And that's kind of where all of this kind of started. And so there is some overlap, you know, with neurotypical community as well as the developmental disabilities community. If there are kind of unique characteristics, I'll try to point those out as much as possible. But when we look at kind of the model for this, there's a model that you all may have heard of either in LEND or in other courses called the biopsychosocial model, where it's an interaction between a lot of different factors. So if you look at, you know, kind of the biological factors, that's where when we talk about genetics and we talk about kind of biological disposition and we talk about any exposure to certain substances. So we have that biological piece that we don't necessarily have control of at birth when we as individuals are born. And this goes back to some of the things I think in our class, in our LEND class at least, we have talked a lot about social determinants of health. And when you guys did the life course game and probably recognized, hey, like a lot of this stuff is out of my control, but still there are consequences for, you know, these things. So we have the biological piece, we have the social piece, you know, when thinking about relationships with peers and relationships within our own family. And then we have the psychological pieces with the coping skills, the social aspects of functioning, as well as that self-esteem and kind of that self-image as well. So I am going to show a quote that just really resonated with me as I was looking at some of the adult literature. So living with the weight of social expectations that do not make sense can have serious mental health implications. So this was a quote from an autistic woman, and she talks about her journey, you know, very transparently that a lot of this is related to those symptoms of autism that she experiences from a social perspective. And I found a video that I think does a really nice job of capturing kind of like this biopsychosocial aspect when it relates to autism mental health. So we're going to watch that. And I just wanted to kind of clarify too, one of the reasons why we will mention autism a lot is because that's where a lot of the research has been done when thinking about developmental disabilities. And it's not that those other disabilities that I mentioned don't have these same concerns. It's actually pretty standard kind of across the board when looking at kind of the most co-occurring conditions, when we look at anxiety and depression, especially, and attention concerns. So I know we'll have kind of a slant, you know, that kind of slants towards autism, but that is just because of what is out there and how some of the other disability communities are you know, doing more work in this area, but maybe don't have as much published yet. So we are going to play the video here. Trying to find my cursor on here. Simon.
It looks like it's muted on the video, like right next to the play button.
I haven't practiced this, y'all.
Would you like me to try?
Yes.
The video?
Yeah, that's
Okay.
what.
This video series was produced from the Autism Mental Health Literacy Guide by the Autism Mental Health Literacy Project, AM Help Group. This video is one of 6 in the series about different aspects of autism mental health literacy. For this video, we will talk about understanding autistic mental health. Challenges with mental health are very common. In fact, 1 in 5 people experience a mental health problem at some point in their lives, and rates are estimated to be higher for autistic adults. Social, psychological, and biological factors play important roles in mental health. This video will talk about some of these factors and how they can contribute to autistic mental health. Growing up in a society that is not understanding, accepting, or supportive can impact autistic mental health, how autistic people see themselves, others, and their lives.
I feel like there's always some social game being played that I'm not aware of. People constantly say things that they don't mean, leaving me mistrusting of most people. I finally got to the point in my life that I looked at everyone with suspicion because I would make plans to meet someone for an activity, and they'd show up half an hour late or worse.
Masking, also known as camouflaging, is when an autistic person finds ways to pass as non-autistic in everyday social interactions. The need to mask can make an autistic person exhausted because it takes so much effort. This can lead to many mental health problems like anxiety, depression, and poor self-image.
I feel really worn out and exhausted from masking and being social at work to the point where I get home and just pass out. I get frustrated because I don't really work that many hours, and yet I'm so tired afterwards. It often means the rest of my night is spent recuperating or sleeping off the workday, and I don't have the energy to do other things, or I stay up very late trying to make up for that recuperation.
There are many social factors that impact autistic mental health. Examples of important social factors are social networks, family, friends, stigma, negative life events, economic disadvantages, housing, education and workplace issues, and the kinds of services or supports people have. We will explore just a few of them here. Some autistic people can thrive when connected with healthy social groups, family, or friends, like to autistic peers who are supportive and help them feel that they matter and belong. However, autistic people may struggle with accessing these social connections. Some autistic people may be in abusive relationships or become involved with inappropriate peers or unsupportive family members.
One thing that gives me a lot of trouble interacting with non-autistics is all the social rules about subtext and hidden meaning that are used in interpreting communication. They use various social rules about hidden meanings to interpret things. As an autistic who tends to be very literal, it can lead to a lot of problems.
School and work are major sources of stress and can have a long-lasting impact on many autistic people. School and work can be full of isolation and social confusion. Bullying and discrimination are big issues. There are many demands placed on students when they go through school and when students need to transition from one school or situation to another. Schools and workplaces need to supply a supportive environment to address these challenges.
Within employment, there's always the extra push to mask and do even more than my best. Never ever complain. Only use positive language. Don't slouch. Smile. Never give your employer a reason to regret hiring you. The job you have is likely the only job you have. And with the unemployment rates so high, it's not like you can just walk out and get a new one tomorrow. You have to show them that hiring an autistic person wasn't a mistake.
Autistic people often report difficulties when accessing supports. Adequate autism-informed mental health supports are rare and hard to come by. There may be barriers in finding them, affording them, or having long wait lists. It can also be stressful to access supports. Many services may not have the right kind of experiences, training, and skills to work with autistic people, which can make autistic people feel misunderstood or not taken seriously.
When I've sought help for my mental health problem, virtually all of the programs that I have been referred to have been designed for non-autistic people and involve things like group therapy and meditation, both of which are distressing to me. Even if I give them a try and find them unsuitable, I'm often labeled as non-compliant, and there are no alternatives made available to me. Even though I recognize that I have a mental health problem and I'm asking for help, there simply isn't any help available for someone like me, and this has had devastating effects on my mental health.
There are psychological factors that impact autistic mental health. For example, one's self-worth or self-image, planning or organizing skills, areas of focus, interests, and passions. Here, we will explore a couple of those factors. When autistic people feel that they are appreciated for their strengths and uniqueness and are kind and accepting of themselves, they can have a positive view of who they are. When you negatively judge yourself because of how others judge and treat you, you can feel ashamed, distressed, and more likely to experience negative mental health.
As a result of the social isolation, my self-worth and image were at its lowest point in high school. However, it has increased steadily since then. It's still sometimes a learning curve for me to remember that not everything that went wrong in that interaction was my fault. However, as I said, my self-esteem and image has increased steadily within the past 9 years, much more than it did in the first 18 years of my life.
It is important for any person's mental health to be able to pursue their passions. When an autistic person's interests are seen as problems rather than as hobbies or expertise, this can make a person feel shame or feel that they are wrong to have that interest. Many autistic people can focus very intently on specific passions, and this can be a source of joy and positive mental health.
Our daughter danced for over 20 hours a week. It was her obsession, but also her greatest love, and her only source of physical activity. It was her safe place, and a world where the work that she put into it was equal to what she got out. Dance was a world that she understood. Unfortunately, it also caused her tremendous physical pain. At almost 18 years old, she was diagnosed with Ehlers-Danlos syndrome and was forced to cut down on the intensity and frequency of dance. Given that she is all or nothing, her inability to give 100% of herself meant stopping entirely. Her grief was unbearable and continues to this day, years later.
There are biological factors linked to autistic mental health. For example, genetics, sensory differences, and physical health. We're going to explore a couple of them here. Autistic people tend to have sensory differences and may either seek sensations or avoid them. When an autistic person gets the right kind of sensory input, the information from seeing, hearing, tasting, smelling, or feeling, sensing, they can feel good. It can be calming or enjoyable. Some autistic people stim, which can be a way to feel calm. It can also be a way of expressing themselves. When a person can exercise, have good nutrition, and generally has good physical health, they are more likely to have positive mental health.
I keep very fit, work out 4 times a week or more. It helps physical health, but also mental health as well as anxiety.
Physical health problems or poor physical health can affect mental health. These are conditions like chronic pain, digestion issues, irritable bowel syndrome, or sleep problems.
I have a condition called Ehlers-Danlos syndrome, which many autistic people have. I do not receive adequate care or treatment for this disorder, which causes me pain virtually all of the time. This has devastating effects on my mental health, as pain makes all of my sensory issues so much worse.
The social, psychological, and biological factors we discussed in this video play a role in how autistic people experience mental health. You can find more information about these factors that impact autistic mental health and more examples in the AM Help Guide. Knowing more helps more. This project is funded by the Public Health Agency of Canada.
All right, let's get out of here. And let's kind of chat for a few minutes, about kind of big takeaways from the video. What really stood out to you all? Yeah, you guys pass the mic.
One of the things was when they were talking about how like traditional methods of therapy or whatever isn't like an apply all, doesn't fit for everybody. It's options that we're able to support.
Yeah, for sure. And we'll talk a lot about that, especially on day 2, about it's not only an issue of being able to access services, it's also being able to access the right services with people that have experience in both, and I think that that can be pretty intimidating to providers if they don't have any experience. And but something that I really recognized from watching this video too is that a lot of the same things that these individuals reported, I experienced the same things. And so there's aspects of this where you think about, okay, they might experience some of the same symptoms, it just might be because of something different. And so kind of getting to some of those root causes and thinking about the coping strategies. Yeah.
Something you said made me think something else.
Yeah.
But I think that but I feel like providers can sometimes be afraid to have these areas that they aren't experts in. So if someone is like, oh, I'm not used to doing therapy with people who are autistic, like I'm not sure, but just because you aren't an expert doesn't mean that you can't, because there's not experts for all the things, for all the people accessible for everyone who needs them.
Yeah, that's a very good point. Yeah. Thanks, Haley.
I think the key takeaway for me from this video, things that I've seen and read too, is just the physical health conditions that also get associated with autism and other neurodivergence. Not even just Ehlers-Danlos, but also things like POTS and chronic fatigue syndrome and other things that are more common than that. I think it's something else interesting to me. I think we look at.
Yeah, absolutely. And thinking about just healthcare, the healthcare system in general for our community and how that is lacking. And so if they're not getting healthcare services related to those physical things, thinking about that consequence on their mental health for sure. Yeah, great point, Simon. Okay.
One woman very clearly was seeking help, she knew that she was having an issue. But some of the other people that were talking were just frustrated by how difficult their day was. So I wonder if it's even just having that self-awareness to know that you need to seek. I mean, that poor woman knew it and was having a hard time, but to be able to understand that those frustrations can lead to something.
Absolutely. Yeah, and I think that's a great point and something that we'll talk about in just a few minutes when we talk about assessment and, kind of how to get kind of information. Right. Yeah. Raz?
I really liked how the video touched on kind of the importance of things like hyperfixation and stemming on mental health for people who are autistic. I think those are terms that get thrown around a lot, or that are people don't really understand the weight that those things can have for people who do stim or do have hyperfixations. And so like the fact that the video touched on, like, there are things that people are going to be very focused on, very passionate about. And if they don't have access to it or if they're shamed for it, it can have a really negative effect. I think was a really important thing to touch on in the video.
Yeah, absolutely. And I know we get into those conversations a lot with families, especially talking about like self-stimulatory behavior, because sometimes we have families who come in from a treatment perspective and they, want their kids to quote unquote look normal and think that that stimming behavior makes them look different. And we have to try to explain also that that serves a very particular purpose for a lot of individuals and that we all do a lot of those things. And that helps us kind of regulate our emotions and how we're doing from an attention standpoint, all of those things. And then when you don't have access to those things, how debilitating that can be, for sure. Yeah, Sarah. Mm-hmm. Okay. Mm-hmm. Uh-huh. And how did you respond to that? Okay. Okay. Awesome. Thank you for sharing, Sarah. We really appreciate your perspective and telling us, your journey. And I realize I'm really bad at checking in with the Zoom people, so I apologize. If anybody on Zoom would like to come off of mute, feel free to do so. If you have any experiences to share, just based on the video of kind of take home points. Okay. One of the things that we're going to talk about now is something that I know has been talked about probably a couple of times within our LEND curriculum, but we can't talk about mental health without talking about ACEs or those adverse childhood experiences. I'm not going to spend a ton of time on them because I know that they've been covered, but just to remind you all, the big ones that we look at are experiences of abuse or neglect, and then also within the realm of household dysfunction and several different things that fall into that category. Looking at violence within the home, looking at parental substance abuse, looking at parental mental illness, and looking at separation or divorce of parents, and then also incarceration. And as you all might remember, there's a compounding effect with this. So the more ACEs that people experience, the more at risk they are for these types of mental health conditions. And there's a really good toolkit that was provided by one of our LEND trainees who is a clinical counselor. And so I encourage you all to check that out. And just to relate it back to our population of kids with developmental disabilities, stats show that our kids are 3 times more likely to experience neglect, physical abuse, and sexual abuse. So pretty horrifying stats, you know, when we look at kind of the risk factors there. And then when we look specifically at mental health conditions in children with IDD, some of the risk factors that really pop out are family functioning, as well as parental mental illness. And so when we, you know, kind of look at this, it's that also, you know, we see a lot of kids with ASD who are susceptible to other risk factors and other ACEs as well. So kind of that trickle effect that we see for the family, just in general. And there was a really interesting article that just came out last year that talked about risk factors that place our autistic youth more at risk for mental health concerns. Some of the ones that they had listed are ones that are kind of traditionally known kind of in the literature. And so we'll go through kind of each of these because I think this can be a little confusing because one of the these are risk factors and protective factors, depending on how you look at it. And so when you look at cognitive factors, how do you all think that that would play out when we're thinking about autism in particular? How do you think it would play out from a cognitive perspective? Whether lower cognitive levels would place you at higher or lower risk for mental health? Any thoughts on that? Yeah, Simon.
I think one thing I think about but the whole like monotropism aspect of autism is that like really intense focus on like 1 or 2 things. And so when you do that, like I think in most like areas of society, like they encourage you to branch out and not really focus on 1 or 2 things, like have those types of restricted interests. And then if you are going to do that, it increases your risk of, you know, all these other types of things like the stigma and things that you might face that contribute to your stigma.
Yeah, for sure. Any other thoughts? Yeah, Alyssa.
I think like going back to our case studies that we've been working on, discussions that we've had on there, I think of just how limited resources negatively impact our, the individuals in these populations. And when there is a lower IQ, and they don't have those resources, they really lack interaction with people. And just thinking of that fact alone, besides all these other factors that could go into it, would absolutely impact mental health.
Yeah, for sure. Yeah, Julie.
I might be jumping ahead though too, but even on the slide before, obviously for autism, the parental divorce and the different parenting styles is ridiculously high in people with any developmental disorder. And I think that plays a huge role because you need the parents and you need them to be on the same page. And I think it's a rare case that you do that, and it's something that you have to work at. But I mean, I've seen it happen a lot. So very tough.
Yeah, thanks, Julie. Yeah, Erica.
I was thinking too, with like a higher IQ, possibly you could feel really isolated socially, so that can lead to a lot of impacts on your mental health too. Maybe there's like a sweet spot.
Yeah, no, that's exactly what the literature shows. It's kind of a mixed bag because on the one hand, you have kids who have kind of lower cognitive levels who need more supports and might have more like behavioral concerns. And then you have some of the individuals that have higher cognitive ability, but don't have the social pieces. So it's that almost like they are bright enough to recognize that they are different, but not skilled enough socially to learn, you know, those skills that help them kind of fit into our world. So the cognitive piece is like really interesting because I think oftentimes when we look at support, we assume a lot based on IQ testing and what people need based on their score. And, you know, what we see here is that a higher IQ could actually place them at risk, you know, for these mental health conditions. So just something to think about. A lot of these other ones, you know, we've touched on a little bit with regards to parents. And parent factors, also with the peer group and kind of social support. Bullying is another, you know, kind of factor that really relates to mental health conditions. SES and just the socioeconomic status of a family, being able to get resources. And then we've already talked about the ACEs, and then the ASD symptom kind of severity is another one that's really interesting, because I think that a lot of times when we look at some of that severity, like Simon had mentioned, with kind of like the rigidity and kind of the inflexibility and kind of insistence on sameness, that can lead to a lot of mental health, you know, conditions. So these are all factors, you know, that have been pretty established kind of in the research. Where this paper provided a lot more information is that they actually asked the parents what they thought placed their kids at risk for mental health conditions. And there were a couple of things that popped out. One is just thinking about the environment and the surroundings that the teen was in and how much it relied on the parents. So to go back to Julie's point, that parents reported that we work tirelessly to provide these antecedent strategies, these preventative strategies to set our kids up for success. And we think that that really protects them, you know, from having a lot of these mental health concerns. School factors, some of the things that were really interesting is just, as you can imagine, like level of specialized support. And also from a social standpoint, being around peers who were similar to them. And so they didn't feel like they were isolated, but they felt like their peer group kind of got them. And then also from a social perspective. So that's where a lot of our programs that we work on, you know, with our community inclusion work and our Be Well programs, that's where this comes into play, is those social activities can really be an outlet. And then we all know how just developmentally things can change in our bodies and how that impacts mental health. We all probably remember what it was like to be a teenager, where you're like, ooh, like Sarah, being a mess. Like, I think that that is probably most people's experience. But thinking about puberty and how challenging that is just in general, and then you add a developmental disability on top of that, and we will have a puberty and sexuality course coming up later in the semester where we'll learn a lot more about that. Another factor that's really interesting to me is their understanding of their autism diagnosis and whether they know that they are on the autism spectrum or whether they don't. And there's a lot of, you know, kind of talk out there about whether parents should share that information, you know, with their child, and whether it's good to know your diagnosis. And what are your all's thoughts? Like, I would love to hear this, and I don't know that we've had kind of this conversation yet in here. Julie?
I just had to have this conversation. My child's not autistic, but like struggles, and I've created a space where he is, I think, aware, like he knows he comes here, but like we've never really like sat him down. And we are currently, we've been denied twice for Social Security benefits, so he now has to go before a court, and he's alone in the room with the lawyer. And so having to sit down and like explain to him, like, you're not supposed to like kill it in there. Like, you're supposed to like look at how much support I help you with. Like, your disability.
Yeah.
And he looked at us like we had four heads, like, well, am I just like the big kids? And I was like, but you are, but in this one space.
Yeah.
You have to. And so I think him not knowing it, like him just being Joe and just being great has served him well. But then I can see the downside because now he's 24 and I'm like, you gotta own it. Like you gotta know what
Yeah.
you're saying. And I maybe should have done a better job of that going up to now because now it's really it hurt, not hurting him, but anyway, I can see both sides. I think that knowing your diagnosis and being comfortable with it, I don't know, I'm talking out of both sides of my mouth, but you can all read my mind of where it's coming, but it was a difficult conversation. And Joe was basically like, I've got what? I'm like, let me just finish with this. We got something in the mail from Muscular Dystrophy years and years ago for like a family outing. And Joe saw it and he goes, who in this family has this dystrophy? And I literally said, it's Jack. Jack has it, like not you. And he was like, that's what I thought. And I'm like, okay, so that's kind of the way we lived it. And now I'm, so.
Yeah. No, thank you, Julie. Yeah, any other thoughts, Brad?
I mean, I feel like for me, I would feel very confused and frustrated if there were barriers to like me living my life. Like if I felt like I wasn't able to connect with people or wasn't able to understand things that other people seem to inherently understand, and there was seemingly no reason for it. I think I would be very frustrated and like very confused, and I think it would make me feeling like yes, something's wrong, but like, what is it?
Yeah.
And I personally feel very frustrated. I think also it's a really important part of advocacy because if you don't know that you need support, then you can't ask for it. So, I think telling a child that they have autism is important, but it's about like framing it correctly and using it as an aspect of identity in life rather than like a negative label or like a burden.
Yeah, great point.
Yeah, I think this isn't isolated just to like a disability. We see this like medical center, like this child's diagnosed with cancer, and the family doesn't want their child to be treated. But one thing that it's not surprising based on my experience, it's not listed on here, is the impact of medical encounters. Seeing greater like PTSD, anxiety, and specific medical type phobias. I see that a lot with a lot of patients because individuals with disabilities have complex needs as well, and have more healthcare encounters than neurotypical peers. And so they're at the hospital and at the doctors and have more procedures and exams. And so not being aware that I have a neurodevelopmental disorder, like why do I constantly go to the doctor and being seen, like is there something wrong with me? And then internalizing something's going on that I'm not being told about what is going on, what is wrong with me, and not being like always forthcoming with that information.
No, thanks for sharing that, Carrie. And I like thinking about that particular paper. I don't even think that they touched on any of the medical stuff. So that's really important to consider. We'll go Erica and then Sarah.
I will say too, I did someone.
Oh, sorry. And then Maria. We haven't forgotten about you. Thank you.
On the like therapy side, I've worked with a couple young adults who have an autism diagnosis, and it was really tricky because they believed that because they had autism, they were stupid and they didn't belong in college. And I hated that because I was like, no, I mean, like your autism gives you like gifts and things. You're really smart in this aspect. He was just like, no, I'm a failure. My mom has to help me with everything. I should just drop out. And he was really, really depressed. He knew about his diagnosis. Same thing with my brother. We also know that he has autism. It's the same thing. He hides it from work. He hides it from people because he's embarrassed of it and thinks it's like a deficit. So I think it's like a tricky, like Ross was saying, like how you tell someone about their diagnosis is really important. I think when they were diagnosed, it was just like, yeah, you have this thing, you're not going to be able to do anything about it, which really needs to be that.
Yeah, and I'm glad that we're kind of prefacing this too, because in a couple of weeks, we'll have a session where we talk about having these difficult conversations and how to do it in a way that is sensitive and kind of takes the person into account. We're gonna go Maria and then Sarah. Maria, yeah. There's Dr. Jones.
To comment briefly about like my experience with my brother, being so close in age, I think I was able to kind of see how his awareness was changing because of our relationship, because we really, you know, like we grew up so close with one another that at a certain point when I was starting to do things that he would not be able to be included in, and even from things of just like being in school and him going, being in a different classroom than me, even though we were in the same like grade level at the time. And then also me being involved in certain sport activities, me starting to drive, those were like certain things where I think that kind of awareness of him being autistic started to happen a little bit more than when we were, you know, really young kids. And that's when that frustration really started to happen. And we started to, I think, realize in ourselves that we needed to have more of a conversation about it in our home, because like, I don't even remember at what age I learned that he was autistic. It was just kind of like our life. It was just like how we were raised with him being in the household. So I think that was kind of an awareness for our whole family that we needed the conversation to happen a little bit more so he could get a better understanding of, you know, why that might be the case in terms of not being able to be included in some of the things I'm doing, but why it's not a limiting factor in him being able to try other things and try things in his own way. So from a cognitive level, I don't know still today how aware he is of it. I think there is a certain level that's there, and I think it's something we're still working on for a longer term, but I think like Julie and I were just saying, like, he thinks he's awesome and he is awesome, so that's pretty much like how I see he's like, if we tell him, he's like, okay, and like, so what, like, why is that, like, I don't get why that's making me not be able to do these things. So it's more so just trying to, I don't know if it's even being awareness of being autistic or more so being aware that the environment around us might not always be accepting of his autism.
Yeah, and that I think speaks to what the that quote about like having to live up, you know, to the social expectations and kind of like society viewing it a certain way. Yeah, thank you for sharing, Maria. Sorry it took so long for us to get to you. Sarah. Thank you, Sarah. And then Victoria, did you have something too?
Both back.
Great. Mhm. Awesome. Thanks, Sarah. Yeah, Victoria?
Hi, I have, my brother has autism and so does my cousin, and it's everybody knows that my brother has autism. But for my cousin, it's something that we all just use different, and I didn't even know my cousin had autism until I was like an adult. So it's like, I swear, like you don't say that he's on the spectrum.
Got it.
At all. But my kind of perspective is he's a Black autistic male who's turning 18, and a typical conversation that we have with, any kid that's born in our family is that, you are Black, there's prejudice, discrimination, and things that you're going to experience in your life, but you should be proud of who you are, and things like that. And I kind of think that autism should be kind of brought up in that kind of same way.
Yeah.
That, there's things that come with this, but this is who you are, and I'm just saying, like, owning his disability and us being able to talk about it comfortably.
Yeah.
And I think that that barrier kind of just stems from like, your parents grew up Black, they know like their life experience, they live that experience, they know the benefits of knowing it when you are young because it starts that young. But for autism, they don't really know. Nobody has had autism from what I've than that. So I think just like being implemented in those societies, like in communities of people who have autism, so like they can like know like, their perspectives and how they were as a child, even maybe could just help on the outlook of everything. And knowing like, are we going to tell him like, even I don't know if he knows. I don't really know like what goes on, but I just know like we don't ever talk about it.
Yeah. Thank you. We'll do Haley and then we'll move on for time purposes.
I was gonna ask a reflective question that I think Victoria kind of answered in a little bit with her example. But in keeping like a diagnosis like a secret or that it's not to be shared, do you think like that adds to the stigma of having that?
Yeah, these are all like great points and a couple of things just to kind of summarize, because I feel like we could sit here and talk about this like all day. But I think there's the element of the difference between apparent and non-apparent like disabilities and how that kind of comes into play. I think the racial and ethnic disparities, which Lauren will talk about in just a minute. And then I also think this idea of the shame related to the diagnosis, as well as, I don't know how else to say this, but like using it as an excuse. That's something I have to work on a lot with the patients that I work with, is that they can't just default to, oh, that's my autism, or I'm autistic, so I can't work on that. And I'm like, and so I think that there's a lot of those pieces that come into play too. Okay, we're gonna have like separate conversation about this because I'm hogging up Lauren's time here, because I love this, but thank you all for the conversation so far. Do you guys need a few minutes break? Okay, let's take a break and then we're gonna come back and talk about assessment. So we'll come back at 2:15.
So I'm so sorry. It was so funny. I was like, for what?
Assessment piece. Yeah.
Oh my God, perfect.
Yeah.
What kind of like things have been brought up?
A lot about kind of like risk factors. We talked a lot about, also talked about kind of like characteristics of autism in particular that make them more susceptible. And then also it's like the role of parents, in prevention.
No, I was like.
Yeah, I think those are the things, and I showed a video that was like 10 minutes. And it was focused on, like, psychosocial, and it had, like, quotes from like, all this. So I think you'll still have plenty of time, because I told them with the ADHD and with the behavior disorder, like we've already, like they've already had those separate sessions. And so I feel like you can go through it pretty quickly. And then I don't know if you saw the ending slide.
I know, I
Take part one, and then like what we'll talk about next time. So just like a percent way. Yeah, perfect. Okay.
Like, it's like. Me too.
Right, yeah. So you could kind of. You just kind of do this. They. That's based on just their physical. Oh.
I haven't looked at my red.
Yeah.
So long.
They told us that they like, girl. You need something.
Like, so the rules for that resume is like, if you got 6 items, actually, it's bachelor's degree. And then for every 4 years of experience.
I said that.
I can't forbid. So like, mine should only be like 1 and a half. Yeah. It might be
Lauren.
Yeah.
We talked a lot about that slide that had this on it.
Yeah.
So I don't know, if you need to, they talked about it in the video.
Okay.
For sure. And then I was gonna talk about how people sometimes mask when they come to see somebody and they try to like look good. And how that can be kind of challenging from an assessment standpoint too.
Yeah. Sweet, that's helpful, then I can move fast.
Yeah.
Did you want to jump in with that with the masking, or do you want me to?
No, I don't need to.
Okay.
Yeah,
Cool.
I think you can just reference the video, you know, because they talked about that.
It's nice that we have the second day too, that we can just.
Sure, because we tried to do it in one day
I think that was my year.
and I was like, "No, this is not working. This needs more time." So I'm glad we're doing two.
Yeah.
So.
This lady seemed cool, found all her stuff, she's like all about. Comorbid mental health, so I was like, I'll get in touch with you later.
Yeah, tell me about it, Dr. Kearns. No, we've had a lot of good discussion.
Cool. I don't want you to switch it to lecture about it.
You don't
Do
want
feel-
to switch what?
Do you feel like you're going back and forth as like lecture discussion?
Yeah,
Okay,
I'll just like pause and be like. Asking for examples.
okay,
If I see like a spot that we should do that,
Yeah.
I'll jump in and be like, what do you guys think?
sounds good. Yeah, that's true. Something with, yeah, I think this would be good to just talk about in people's own words, like
Yes.
what comes up.
Exactly.
Okay.
And then I think the meat of kind of like what you talk about are probably prevalence, the racial, ethnic like disparities. And then kind of breeze through the ADHD and behavior.
Okay, perfect.
Yeah.
Love
I
it.
feel like those are the more important things that they haven't had yet.
Okay, sweet.
Yeah, and Victoria, I don't know if you were in here, brought up a really good point about her brother as a Black man. Yeah. Okay.
Sweet. Thank you.
Good. I'll be right here.
No.
Unless you don't want me here.
No, obviously.
Come on. She does a little thing, which I don't. I realize. So like there's. And then she comes
Okay, sounds good. We could talk right after this. Okay. Do we wanna get started or give a couple minutes? Okay. All right, everybody, we're gonna roll on back. Get started again. All right, so sorry that I missed the first half today, so Jen will just jump in if I'm reiterating anything that we already talked about. But we are going to move into assessment of mental health disorders. So this has become a really important topic that has gotten a lot of really good momentum over the last couple of years, and just the importance of knowing to screen for different mental health concerns, how to adequately assess them in individuals with DD, and then, you know, how to make recommendations from there. But that really key piece of always assessing to see if there's any changes that the individual has experienced in their mental health. So kind of the quickest scan would be a mental status exam. So this is more of just going through a checklist of symptoms to see how somebody's doing. It's really helpful to kind of have a baseline for that individual so you can see if it's changed at all. But that can kind of give you a cue that there might be more that we would need to assess for. But then the key is doing a really comprehensive psychological evaluation, specifically asking about all the different mental health concerns an individual could have. So I think, you know, over the last couple of years, we've seen a really good shift where now, you know, we might spend the first half of the diagnostic interview looking at, you know, signs and symptoms of autism or intellectual disability, but then we're kind of moving into all the other areas of concern. So anxiety, depression, eating, sleep, all the things that we need to kind of assess for and see if there are any other comorbid concerns. Symptom rating scales are also really important. So making sure that we have a parent report of anxiety, ADHD, depression, and a self-report as well for those. And we'll talk about some of the difficulties that come up with this in a second. And then a functional behavior assessment too. A lot of times this is used in treatment settings or in school settings to try to figure out, okay, we're seeing this behavior, but what is the function behind that? And we really want to go as deep as possible with that. So we don't want to just be thinking about like, oh, we're seeing aggression. We want to think about, well, what might be causing that aggression? And, you know, many times it is some of these mental health concerns. So it might be anxiety that's underlying that, or it might be depression that has been ramping up recently. So just kind of broadening what we typically think about as a functional behavior assessment and using that as a way to screen for mental health concerns.
And Lauren, can you describe what comorbid means?
Yeah, so comorbid would be like a co-occurring diagnosis. So if an individual would have autism and anxiety, or intellectual disability and depression,
So
just
the
kind of
same
two
thing
things
that we've
together.
been talking about, a lot of people refer to it as comorbid conditions or comorbidity. I think have moved away from that a little bit and use co-occurring, because morbidity just sounds bad.
Yeah.
And it has a lot of just stigma, you know, related to it. So just wanted to kind of jump in so you guys knew that's the same kind of co-occurring.
Sweet.
School diagnosis too.
Yeah.
Yeah. I will use that, co-occurring. That's helpful to know. Okay, so when thinking about assessing symptoms, we want to get a more holistic assessment that can help cue us into different mental health concerns. So one of the things that's really important to figure out is, are there any changes in sleep, any changes in appetite, any changes in energy level? So an example would be, you know, I was working with a patient during COVID, and the individual's nonverbal, and their mom kind of logged on and was just saying, it's just the weirdest thing. Like, he just randomly, you know, stopped sleeping, and he is not really going outside. And that used to be his favorite thing, you know? And so that immediately cued us that maybe we're seeing some depression. And so we assess further, you know, from there. But sometimes in the absence of other reports of symptoms, it's really helpful to get like those behavioral markers or those behavioral changes, and then drill down into why might be seeing that. Family and direct care staff can be really useful sources of information too. So we are, you know, totally excited to get anyone's perspective. And a lot of times, some of the people that might be working with your child at school, you know, have some of the best ideas of what was bringing them joy and what they've seen change in that, or what are some of the things that they feel like they do really well with, and then where do they see a lot of anxiety come out. So that can be really helpful to kind of get multiple reports. But one of the big things I'm trying to figure out with mental health concerns is a lot of times that change from baseline. So I'll try to kind of take the timeline back as far as possible, you know, so what were they doing when they were 5? When did you notice this shift in kind of a lack of enjoyment with activities? Or when did you notice that it felt like whenever you left the house, your child became anxious? Because for some of us, that's been more of a longstanding pattern, you know, since age 2. And that would maybe cue us less towards a co-occurring mental health concern. But if we see that, like, wow, there was an abrupt change at age 7, that is going to really lead to some of those further questions about whether this might be a co-occurring mental health concern. Y'all talked about this, and the video talked a little bit about masking. So just kind of this idea that a lot of individuals have all of these stressors from trying to mask throughout the day. And this can be some of the many things that are kind of adding up over time to contribute to depression, anxiety, low self-esteem. So we just kind of want to assess for these, and then also think about, how do we intervene if those are some of the things that have led to the mental health concern, then those are some of the same things we're going to target as being able to help the individual with. But we have a lot of challenges to assessing mental health concerns in the DD population. And I think one of the biggest things is just being really behind in this area as a field. So, you know, a lot of our self-report or parent report measures are not normed on individuals with developmental disabilities. They weren't created for individuals with developmental disabilities. And so we're trying to apply those same measures and give them to individuals with disabilities that, you know, we may need to think of different ways to ask these things, or symptoms may present differently. And we're kind of behind on the research game on that. So I'd heard something about like 15 years, you know, if the mental health field in general is like 10 years behind, then mental health in the DD population is, 15 years behind or more. So just kind of having that lens that we're playing catch up, where however many measures we have out there for anxiety right now, we have, way less for individuals with autism or individuals with intellectual disability. So some of the difficulties with self-reporting, communication challenges can be difficult. So just thinking about ways that we might be able to assess mental health concerns in individuals that are nonverbal or have a lower reading level. And then some of the symptoms of autism can make it difficult too, to kind of connect your emotions to like just that emotional insight can be a little bit difficult. So if somebody's just asking you like, have you been anxious recently or have you been depressed recently? It might be difficult to put that into words. So we need to figure out creative ways to assess for that. And we really need to not assume that, an individual just saying no or moving on from that doesn't mean that they're not experiencing that, right? We need to be more diligent about kind of following up and thinking creatively to figure out, did we really get the right answer to that question? Also, medications can often mask mental health symptoms. So sometimes we meet with individuals that have been taking medications for a number of years, and maybe that's kind of leading to lower levels of anxiety, or we're not seeing symptoms of ADHD present as, directly in the assessment. But that may be because that individual is taking medication. And so if we don't give that diagnosis, or we take that diagnosis away and say they no longer meet criteria, that's really kind of dependent on the medication, and would definitely be our mistake at missing that would still be an underlying diagnosis for that individual. So what do people think about in their experiences in their fields? What have you noticed about some of the difficulties with assessing mental health concerns? Yeah.
Provider, but I think having from a parent's perspective, their own lens on it, and maybe discounting or maybe just not seeing it clearly for what it is, or seeing it from your own vantage point and not being able to document it as well, because I don't know.
Mm-hmm.
See it coming from, it's like your idea of what you're seeing in your child, and
Yeah.
that might not be how your child's feeling.
Totally. Yeah. And the fact that you're with them every day, and it's like, it's hard to kind of say like, oh, there was this change. A lot of times parents, it's more after I've asked a couple of questions, they're like, oh, now that you bring that up, I am wondering whether that changed a while ago. So that's a great point. Yeah.
This is a challenge that's not specific to people with intellectual or developmental disabilities, but there is such a stigma around the documenting, especially of mental health conditions. That I find that families are often reticent to discuss those issues, or if those issues are present, they'll say, gosh, can you not put anything in the note about that? Because
Yeah.
I don't want this to be something that is on the child's permanent record, follow them throughout their life. And it's, that becomes a very challenging conversation too, because we need to be able to assess and treat for these things. Recognizing that certainly there are sources of stigma, even within getting health insurance, getting life insurance.
Right.
Life.
Yeah.
It's real. That's very difficult to deal with.
Absolutely. That's a great point.
I think also in this setting, we are less likely to have time. Like if we're working with kids with a kid, just a kid, not just a parent in the room, and sometimes they might not feel comfortable talking about those things. When the family member is present, and so they might just not have the setting, even if they have all that awareness to express it, if they're not comfortable with it.
Yeah. That's a great point.
Mine is also not for people who have developmental or intellectual disabilities, but I do work as a school-based therapist at school, so I have to diagnose students with MT. And when talking to teachers or principals, there's just a lot of words that you probably shouldn't use to describe a child. Well, they're a bad kid, they do this, and it's not really, they're non-participatory, that's not saying it nicely, but they don't say it like that, and things like that. And I think if it was anybody else or somebody else, that can really put a pressure on somebody who is diagnosing or assessing somebody else, to just be very, not really, cognizant of the students' mental health and that.
Totally. Yeah. Everybody, I love, yeah, all the points that were brought up about stigma, these things looking different in different settings. Nicole's point made me think about, like, a lot of times when we're diagnosing individuals in therapy, we might wait until like the third session to diagnose them after we get to know them and see like what their concerns are, what might be contributing. But in assessment, it's usually like quick, we just met them. And if you think about, like, would you want to tell someone you just met all of your mental health background while your parents sitting there? Or while you're doing a cognitive assessment that feels a lot like school? Probably not, right? So, it's a very multifaceted issue. And then once we give that diagnosis, what is that child, facing when they go out into the world, with kind of the pushback and the stigma they're getting from there too. So any other points along those lines? No? Okay, cool. Oh yeah, Sarah, sorry. Yeah.
Yeah, I know I need it.
Yeah. Thank you for sharing that experience, because that's super helpful to kind of think about the lens that, people might be feeling in these appointments. And it's just, yeah, it's something we just need to keep getting better at. And we need to have minds towards this going forward to try to help. Any other points people wanted to make? Dual diagnosis. So we'll talk a little bit about prevalence. So we know that mental health conditions, the prevalence of them is higher in adults with IDD, including ASD, and very drastically so as well. So one study found that 78% of children with ASD had at least one other mental health condition, and then nearly half had two or more. So this is not a rare occurrence. This is more so the norm than it is the exception, which is even more important about like being on high alert and figuring out, are there other concerns that may be going on? And then we're seeing in this study, it was looking at 14.1% of children without autism had mental health concerns. So that's just kind of highlighting the disparity that we're seeing a higher level of individuals with developmental disabilities having co-occurring mental health concerns. So I found this person in my research and I thought she was super cool. Her name is Dr. Kern. So I was like kind of nerding out over her, but she got interviewed and had like a couple of really cool quotes. But her research is all on mental health in kids with autism. So she talks about for a long time, mental health in kids with autism was neglected because the focus was on autism. There's much greater awareness now, but we don't have enough people trained to provide mental health treatments to kids on the autism spectrum. We need to bridge these two systems and the different sets of providers that tend to treat these children. So generally, in our field, kind of the way that things are historically set up is we have individuals that are trained in DD and we have individuals that are trained in mental health. And a lot of times people are kind of bounced back and forth between those two systems. And we don't have a lot of people in the middle that are trained in both and are doing both and that are developing treatments for both kids with DD, kids with mental health, and then kids with DD and mental health. Does anyone feel like they kind of see this coming up in their work or in their personal experience? Or anyone notice anything about kind of this separation that we tend to have? Thanks.
One thing I wonder about is like, so it's a 78% of the kids with autism had a co-occurring mental health condition. I'm just kind of curious, like in the 22% that didn't, like what was their situation? What was their protective factors that enabled them not to? Because that was something I struggled with at the beginning of this presentation and talking about it more. It makes more sense to me, like why there is like a need to diagnose mental health conditions and people with intellectual developmental disabilities. But just like to me, like I guess I always kind of figured like things like depression, anxiety, OCD are so like central to the experience of people with ADHD and autism that like, I don't know, like I guess like that's the thing to me, like that 50% we just have. I'm just curious to know more like what is their situation and how do they end up not having it, I guess.
And Simon, I feel like we'll talk about that more in part 2 when we talk about things like treatments and like interventions that are helpful. So let's come back to that conversation.
Yeah.
Because that is kind of like we present all of the today, and then we present like more of like, here's what we can do to be, you know, more effective.
Yeah, I think it's a great point to just thinking about like, what's that kind of other bubble of the Venn diagram in a way. For me, it's really that's why I always come back to like the change in baseline, you know, because for me, it's really concerning, like those things where an individual was getting a lot of joy from this, and then we just saw that decrease a lot. Or, you know, they seem to be, you know, really enjoying things socially and then felt like they started withdrawing. Like when you see that change, that kind of cues you to think more, okay, well, this individual has had this developmental disability, but now we're seeing this change in how they're doing or how they're feeling kind of thing.
I think that it's also important to think about that like from a non-disability standpoint as well. Like, especially now, like given the prevalence of mental health conditions just in humans, you know, what are those protective factors, especially right now with the world the way that it is. So yeah, we'll talk a little bit more about that, I think, from a system standpoint.
I think what I've seen is if there are like with patients, any type of like significant noticeable behavior change, there's never a question if we need to assess if there are any mental health conditions. It's always there's a medical reason for this and we have to work them up for X, Y, and Z versus even considering any other diagnosis in the mental health capacity.
Thanks, that's super helpful.
Sorry. I think for me, when I worked at the College Counseling Center last year, there were a lot of young adults coming in that had ADHD or autism, and they kind of, the supervisors were not comfortable with treating mental health disorders on top of the other stuff. And it was just interesting because I got a lot of the referrals that had autism because I had some experience, like other people didn't. And I was like, this is a great place for people to learn how to do both at the same time. So I felt like it was a loss a little bit that I was giving everybody and other people weren't given a chance to like try, because we do need, especially for young adults, I mean, they lose all their services after they leave like children's or when they turn 18 or 21 or whatever, because they don't have anything.
Totally.
Yeah.
Yeah. And like we need people in the community that feel comfortable treating both. So that would have been a cool learning experience, but yeah.
I think part of the way I think about this too is just like the hyper specialization of the medical workforce in general. maybe back in the day, you used to have like, your family doc who could do a little bit of everything and like, that was good enough. But the fact now is that we have so much medical knowledge and so much kind of, there has been a lot of growth in like what we know and what approaches work. But the side effect of that has been that it's very difficult for one person to sort of be able to diagnose and treat and address, medical comorbidities or co-occurring conditions and, deal with mental health concerns and, be like a therapist.
Yeah.
And the fact of the matter is that in much of the country that is not served by giant institutions like ours, there may not even be people who do one of those things.
Right.
And so that's something that I also think about when we think about like how we bridge this gap.
Yeah.
Yeah. It's so true.
And that's where a lot of like the work that we do with Autism Echo program kind of helps with that from, just a capacity building standpoint.
Yeah. And it's so hard for families, right? When they like have waited on this wait list for a year and then they come in and they're told that, oh, I'm not the specialist for that. I'm going to put you on another wait list for this person who's just a slightly different specialty. It's hard for one person to kind of go up against that system. So yeah, just something that we can keep collaborating on. Another quote from the person I'm obsessed with currently. It is crucial to detect mental conditions in children with ASD early on because the longer these problems go untreated, the harder they are to treat. Right now, we don't have a great system for that. So just thinking of like kids in the school system, that might be struggling with anxiety or behavior or depression, from kindergarten. And then we see them, when they're in 5th grade. And now we've got a lot of other difficulties that have kind of stemmed from that untreated mental health condition. So now we're going to move into a little bit of the racial and ethnic disparities. So one thing that's, really important to think about is that intersectionality piece. So how dual experiences of ableism and structural racism may have a larger negative effect on the health of autistic people of color than either one experience alone. And we can kind of add mental health and mental health stigma onto this as well, where we're seeing a lot of intersectionality. And this can also contribute to kind of why some people may be developing mental health conditions, whereas others aren't. We know that adults with intersectional identities might feel a greater need to mask both their autistic traits and psychiatric symptoms in healthcare settings to avoid that further stigma and being further marginalized. So this is gonna kind of add on to those disparities that we're seeing and make it more difficult to diagnose and get appropriate treatment. So just thinking about the ways that barriers are kind of compounding against people in this space. So we do see that, coming out in statistics as well. So there was a study from 2022. So I think it's really interesting to think about, like, we have seen, a lot of movement in this area, but then we've still got the disparities and we're seeing, similar statistics. So we still got a long way to go. So in this study, among the autistic group, Black, Hispanic, and Asian adults were less likely to be diagnosed with psychiatric conditions compared with white adults. So, we're not doing an appropriate job of screening accurately. And then we see similar differences in psychiatric diagnoses among non-autistic adults. So very similar disparities, but we just have that intersectionality piece. And then the diagnostic pattern among adults who are autistic and Black suggests that this group might experience unique difficulties receiving mental health diagnoses. So just thinking about that intersectionality between being autistic and being Black would put you at a greater risk of having somebody miss a mental health diagnosis. And then we also know that we can be at a greater risk of missing developmental disability diagnoses as well and be more likely to get behavior disorders. Or, we can have autism, but be more likely to get a behavior disorder and miss like the anxiety or the depression that might be contributing to that. So just kind of knowing that even in 2022, we're still seeing those same disparities. Any thoughts on that or questions?
Yeah, I think this goes back to Victoria, what you were saying, you know, from your brother's perspective. So we have mental health, we have autism, and we have race, you know, and all of those intersecting. And from a provider standpoint, you know, being able to provide appropriate care from just the mental health and just the disability standpoint is complex enough. And then you add culturally competent care or responsive care to that, it adds a whole other layer. And so you can see why there is that disparity of like, why would I seek this out, you know, from providers who might not be like able to serve me. So part of this is kind of recognizing, oh, it like when you start to look at the understanding of why, like it starts to make more sense of like, okay, why is this and what can be done about it?
Mm-hmm. Kind of went over this. I think the main takeaway from this is that some of the symptoms that we're seeing can present differently, but we are still looking at the same underlying mental health diagnosis. So we can still diagnose anxiety, depression, ADHD, bipolar disorder, but those symptoms may present differently, and that's why we need updated screeners and new ways of looking at things. But what we'll talk about next session, which like Jen said, will be a lot more uplifting, is that, you know, it's really important to individualize treatments. And this is where things can get really fun and really creative. And we can think about, we have all these great resources, you know, from the DD treatment field. And then we have, you know, some mental health resources. And for me, that's just like, usually it's just a better manual. So like we do Facing Your Fears, which is anxiety for individuals with autism. And it's just a way better manual than any anxiety manual I've seen because, you know, we have visuals and we have all sorts of cool stuff. So I think just this is probably where our field is going, is just having more of that universal design type of mentality where like this can help everybody. So let's figure out how we can adapt materials and go from there. The most common co-occurring diagnoses that we see, ADHD is very common. So that used to not be able to be diagnosed with ASD at the same time, but now it can. Behavior disorders are commonly diagnosed, but then we see as individuals get older, they're more likely to have anxiety or depression as opposed to a behavior disorder. It's also interesting to think about, are all of those behavior diagnoses true behavior disorders, or could that be a different mental health concern that we're missing? And then anxiety is extremely common and depression is very common as well. Yeah.
So your point about previously ASD and ADHD not being able to be diagnosed together, can you speak more about that? Because from my experience, like they're like tried and true, like normally a lot of the time.
Yeah.
Happen together. So can you explain some more about that, if you know?
Totally. Yeah. So I think the background comes from what you just said, which is that it used to be the idea that autism like encompassed a lot of attention and hyperactivity difficulties. And so they were saying, if an individual has ADHD, it's better explained by the autism diagnosis. But now there's an understanding that individuals with autism, although there's some attention and hyperactivity concerns within that, there are definitely individuals that kind of go above and beyond, but what would be expected from just an ASD diagnosis. And so those individuals would meet criteria for both ADHD and ASD.
And one of the ways that I kind of think about this too, based on family conversations, is sometimes families come in and they have like the autism piece kind of under control and kind of well managed. It's the ADHD pieces that they need like more support with. So thinking about it from that standpoint of like, it can be like Lauren said, above and beyond what would be typical. But in the past, in just as recent as the previous DSM, it was not, you weren't supposed to get those two diagnoses at the same time. So this is relatively new, which shows what Lauren said about we're a little behind.
Okay.
Trying to catch up. We're trying our best. That's why we're here. What time are we gonna wrap up?
Probably soon.
Okay.
So if you,
Go to the wrap up, maybe?
yeah, so the reason that we're skipping some things, we know that you all had the ADHD talk last week, and I think you've already had behavior with Dr. Curran. Or maybe soon. Okay, we're having a lot more on disruptive behavior. And so we wanted to get to kind of things that were more unique to what we're going to talk about next time too.
Yeah. So, with that, kind of our main takeaways from today, and I think we got to all these, which is good, because we could have just skipped right by this. So, you know, people with developmental disabilities are at a greater risk for mental health concerns, making it very important to accurately diagnose and treat. Racial and ethnic disparities are very prevalent in the intersection between DD, mental health, and racial and ethnic disparities. Assessment of mental health concerns in people can be in people with developmental disabilities can be challenging, but it's absolutely necessary. So we just need to kind of be creative with this and figure out some good ways forward. Mental health concerns may change over an individual's life. I did not get to that.
There's a slide. I think it's maybe the slide. Yeah.
This
right
one.
there.
Yeah. So this is kind of some of the common trajectories we see. So younger children with DD, they often are going to be more likely to get externalizing diagnoses in addition to DD, and then internalizing disorders start to develop as children age. So next time we're going to focus more on anxiety and depression and treatment considerations, thinking about kind of that middle childhood and adolescent age group. Oh no. And then in part two, yeah, so we're basically going to talk about treatment, and it's going to be really cool. And we're going to be like, all right, what do we do with all these problems and how do we fix the world? It'll be awesome.
Yeah, the first part, not so uplifting because we're going to talk about anxiety and depression. But we'll wrap it up talking about treatment and things that are happening.
Yes. Yeah. Cool. Any questions or things people wanted to share?
This may be a broad question, but I was wondering like about trauma in particular and how that like intersects with everything. Because it doesn't have like a lot of kids don't really meet criteria for PTSD, but there's definitely symptoms of that. Is it more diagnosed as like an externalizing disorder?
I think we can diagnose PTSD, right?
Yeah. I would say that there's a high correlation between mental health, concerns and trauma, because of like the ACEs studies that are out there. We'll talk a little bit about like the importance of trauma-informed care from just kind of like a system standpoint next time. But yeah, I think that is something that is becoming much more relevant as we recognize more about like just the significance and like the prevalence of trauma in not just kids, but adults.
Sweet.
I had a
Thank you
question.
all.
From
yeah.
Zoom.
Hi.
Hi. This is from a while ago when we were asking questions, but I was just wondering if you've had instances in the clinic where you were beginning to talk kind of about mental health status for the child, and you began to have some concerns maybe for the parents or the caregivers that were giving this report, but for themselves, and kind of what the process looks like for that to maybe have like even group therapy, or what next steps were to have more of a conglomerate like family practice to address these things.
Yeah, that's a great question. I would say right now, the system that does come up a lot. And I would say right now, the system that we tend to gravitate towards is connecting that family with social work. Or if it's more of like they could use some social support with the diagnosis, we could also connect with family navigation. But the social work team has been helpful in kind of connecting them with an adult provider. I would say that's kind of a gap for us right now. Like we don't have a lot of places like for parents to go for their own care that's really within our system. It's more so community providers. But I think that's definitely like a good area of growth.
Our social work team is amazing. There's many of them kind of on Zoom right now, I think. And they have a lot of really great resources of adult providers. So we definitely try to screen for that, because we recognize also just the genetic component of that. And so it would be a disservice to not, but then we also want to be able to provide resources and suggestions and not just kind of open that up and leave it hanging.
Add on to that, actually. Sorry. That's a great point, actually, and social work was never offered to me as even an option, and I had like my adult provider, just even talking with it, suggested maybe you want to see a therapist. I feel like it should be more of a conversation. I mean, I know you can't do referrals, but when you're working with the families, if you notice, someone who's just stressed out, right, or it has like a ton going on, or comes right. I don't know. I feel like it should be much more of a natural conversation so that parents know. And if social work can help, that's even better. But I think it should be offered to that conversation should come up for every parent. Is the appointments alone, the scheduling,
right?
All of that. It took me years to take advantage of it, but it was like different appointments that I didn't hear like IOB, to be honest with you.
Right, totally.
It's been nice to have had that in the 22 years I was in children's.
Yeah.
Well, and that's kind of like the point of Blend in general is like, it's awesome that Ruthie, from OT is asking about this and now knows that there is support, for adults and parents that we can provide.
Yeah.
My point.
Yeah, totally. And that's one of the reasons I would find it so hard to leave Cincinnati Children's, because this amazing social work support that we have. I feel like when I hear of those family stressors, I'm like, okay, I know who to connect you with. This is going to be helpful. And I think it's just like a really good systems level care.
I just didn't get that.
And our social work friends.
Yeah.
Picked up on my stress.
Right. Yeah. So.
I think that's a great question and a good point. I know like something for you all to like maybe look into and think about is like children's is like piloting like that heart, mind, well-being center that focuses on a very specific cardiac condition, and it provides mental health support to every member of the family. So it's not just the patient, but the parent and caregiver receives support, and same with the siblings in this center. I know in the United States, this was very hard for them to roll this out here because of like reimbursement, because you have all these people as a patient, and how do you do that insurance wise? This is more readily available in other countries. But just an idea that it is possible. It just is a lot of, planning and kind of collaboration on, is this where like we could all be coming in the future with providing support to all members of the family, because medical and mental health and disabilities affect every member of the family. And so we often do miss the caregivers and the sibling aspect in that sense.
That's really cool. That was kind of exactly what I was talking about. So that's cool to know that that's already starting with in a particular area. Cool.
Yeah. Thank you all.
Thank
for the
you all.
engagement and discussion.